Good afternoon, everyone, and thank you for coming. Again, there are many things happening at Hoag that the physician and medical staff in general aren't familiar with, and so we like to highlight that, spotlight it periodically. And that's the purpose of today's presentation by Dr. O'Megan, who's an intensivist here at Hoag, and has been very active throughout her professional career in the issue of organ donation and organ harvesting, and she's the queen of it here at Hoag. She's been here for a number of years. She's chair of the Organ and Tissue Donation Council. She developed the Hoag donor recognition, and if you ever come outside the door of the emergency room, you'll see the Tree of Life and the Book of Life identifying out of gratitude those families who have given an organ of their loved one in order that someone else can live. She's an instructor in the One Legacy Simulation Center as well. She went to school in Auckland, anesthesiology as a resident, did her fellowship in critical care there in Auckland, board certified therefore in anesthesiologist and intensive care. She's currently chair of the critical care department here at Hoag. She's an intensivist full-time. Those ladies and gentlemen have been transforming the care we provide in critical care by being there on the spot all the time. She was associate director of the Trauma Life Support Center in Mercy Hospital in Pittsburgh. She was assistant professor of anesthesia and critical care at Penn. She was an intensivist after her training in Auckland, and she has many other responsibilities when she was at the university and here at Hoag as well. Your papers in front of you list her educational goals. Please join me in welcoming Dr. O'Megan.
Thank you for the introduction, Dr. Selecki, and thank you everybody for the opportunity to speak to the topic of organ donation best practice. The goals for this presentation are to discuss donor management and best practice, and in particular identify the role of the physician in organ donation, and we will also touch on many aspects of the process. There are many moving parts in the topic of organ and tissue donation, and I would like to emphasize gift law and the donor hospital best practice. So the question to run on for everyone in the organization and here at this presentation, how can I utilize this information to improve donation practice at my hospital? And there are many ways that people can help. You don't have to be a physician to actually be engaged in this practice. It is also very much related to the community that we serve at Hoag Hospital. Organ donation and tissue donation is a human issue with a very human impact. How many of you know somebody who has had either tissue donated or else organs transplanted? And then also we have to remember that tissue is highly used in the Hoag system. We aren't a transplant hospital, but we actually support the system. So I will introduce this topic by something that as intensivists and care providers in this hospital, this is a fairly frequent presentation of somebody who comes to our neuro-intensive care unit. A 45-year-old male found unconscious in the bathroom at home. He's comatose, hypertension, tachycardic, and has little respiratory effort when found and is intubated by the paramedics. On arrival to hospital, it is confirmed that his endotracheal tube is ventilating adequately. He remains hypertension, tachycardic, and medications for control of blood pressure are initiated. Again, he remains comatose. Workup shows a head CT scan with extensive subarachnoid hemorrhage. There is an anterior communicating artery aneurysm found on further radiology studies, and this is managed by interventional radiology coiling procedures. All this happens day and night at Hoag if we have somebody presenting in this manner. The case history is important. There are no medical or surgical problems per the family, and there are no immediately abnormal laboratory studies, although urine toxicology comes positive for cocaine and amphetamines. The ICU management is really standard. We ventilate the patient, we manage blood pressure, we give intravenous fluids, avoid hyperglycemia. There is anti-vasospasm therapy, and also anti-epileptiform medications are administered. However, despite all the interventions, this patient's intracranial pressure rose and became refractory to treatment. Pupils became fixed and dilated. There was no response to central pain, and death by neurologic criteria was established some 12 hours later. And then it was found that this patient was registered as an organ donor. So what are the next steps here? We have a lot of moving parts that are going in parallel and series. There is donor support, then there is the organ procurement part of this, then there is organ transplantation. And within all of this, the family requires a tremendous amount of support, not only from the time their loved one arrived in the emergency department and critical care area, but then as you move through the organ procurement and donor support area, the family is often having a vigil at the bedside. I'd like to move into a little bit of history of transplantation. And allotransplantation first turns up in the literature around about 300 AD. Cosmos and Damien, who were twin Christian priests, and they also had medical care, they also oversaw the leg of a deacon that was amputated to treat some cancer. And then the leg of a recently slain gladiator was retrieved from the battlefield and transplanted to the amputation site. Now there has to be a little bit of allegory here, and again tissue matching here isn't quite what it would be in our time, but again this is just of interest. However, I did not know till recently that in 1668 the first successful bone graft was performed in Holland, where dog skull was used to repair a defect in a human cranium. And then there was a soldier's nose grafted in 1746. Interestingly, the first human blood transfusion occurred in 1818, and this was many years before the ABO blood groups were discovered. Skin grafting started in 1881, and then we move more to the first human kidney transplant using a xenograft in 1906. Heparin was discovered in 1912. Blood transfusion became established in 1918, and then transplantation really started to move ahead in leaps and bounds. There was the first successful kidney transplant in 1958, followed soon after by lung transplantation, then liver transplantation, and pancreas transplants. In 1967, we will all remember Christian Barnard and the internationally acclaimed heart transplant, and I think this put donation and transplantation onto a whole new level in the international arena. Then we have immunosuppression getting developed in the late 80s, and then living-related liver, lung, lobe transplants were commenced in the 1990s. Hand transplants followed, and then there was the first lung transplant from a non-heart-beating donor in the year 2002. And around this time, face transplantation also started. Now, we are all aware that there is a national organ transplant list. And if you look at this, these are the number of deaths along the years, the number of donors, and the number of transplants. And there is an increasing gap over the years between the number of transplants and the number of people on the waiting list. And I think this is something that we all, as members of a community anywhere, need to know about, because this is getting into a public health crisis. The supply and demand is just outlined here. These were figures that I got from a national database this week. For January-November period last year, there were a total 26,500 transplants in the United States. And of these, 21,000 were deceased donors. But there is an ever-increasing living donor pool for transplants. And I read recently that in some areas up to 42% of renal transplantation may be from living donors. This also puts things into perspective. Here is the national waiting list of 121,000 people. Obviously kidneys and then livers have the most predominance in the waiting list. This is California state, and we actually have a very large number of the national waiting list. And then the greater LA area, is that served by One Legacy, and we are in that area. And look at the penetration, 8,257 of the state waiting list are actually in the greater LA area. Many people die waiting for an organ transplant, and the figure for 2012 was over 1,100 people. And for the first half of last year, there were over 575 deaths. And also, there are some people who are on the waiting list who just become too sick to wait any longer, and they drop off the waiting list. So this is another hidden number in the whole system. So we have an increased demand for organs, a limited donor pool, so it's very much a human issue with human impact. And this is why I feel that everybody needs to be well educated as a member of a caregiver team and a member of a community in this country and locally about what is involved here. So what can we do? We're a community hospital, we're not a transplant centre, but we certainly as physicians and members of care teams do refer our patients to hospitals in the local area for evaluation for transplantation and listing. And then Hoag also has a very high use of bone and tissue as a community hospital in our operating area. It's important as members of the healthcare team that we preserve the option of donation. Over 49% of the adult US population is registered to be an organ donor, and people can register at the age of 18 and over. It's known that more than 75% of families consent with an optimal approach. And even although this would seem to be a very traumatic time for people with a lot of grief and this burden, in the end there are psychological and grieving benefits for the families of donors. At least they believe something good comes out of something bad. It's important to know what we can do. One donor can result in up to 8 life-saving organ transplants, and one donor can result in up to 50 life-changing tissue transplants. And there is actually a handout at the door which outlines all the different uses of tissue transplants and bone. So what do we do in the critical care unit? We have patient management goals that are there for the patient, like the one I mentioned earlier in this presentation. But what is good for the management of the patient, by good fortune, is also good for a potential donor. So whatever we do for a patient, actually, if they cannot survive and do wish to be a donor, we're not in any conflict medically or morally or ethically, which makes the process easier. We have devastating brain injury guidelines or catastrophic brain injury guidelines. These are called CBIGs, and they are the basis of good neurocritical care. It's just an algorithm. And there are many of these published in the literature. This is one that came out early in 2008, but we actually have our own algorithm based on what was developed at UCI. The components of support orders are nothing new to anybody who would have worked in a critical care area. We need to maintain adequate blood pressure, hydration, we address sodium and water balance, urine output, diabetes insipidus, if it's present, we diagnose and manage. And then we also maintain oxygenation and monitor labs. All this happens 24/7 in a critical care unit, so there's nothing extraordinary here. Why do we wish to improve donor management? It's really important to make sure that what we do does not impact in a negative way on the potential for organ donation, or the corollary is what we don't do we may actually impair the opportunity for somebody to donate. By facilitating good care, we also provide a better outcome for the family. We can transplant as many organs as possible. And then one important thing is to have good organ function after transplantation. Why are CBIGs important? We can preserve the donation opportunity best, and as I've mentioned, care goals and donor support goals are not in conflict. And it's now well recognised in this country in many publications that the use of these goals increases the number of organs available for transplantation. So what about the role for the intensivist, somebody with my job? We manage critically ill patients every day of our lives. And we actually manage the whole patient, not just a single organ system such as renal function or pulmonary function or whatever. So we're well versed in how to manage a total patient with multi-system issues. We manage shock states every day and address hypoperfusion. Donor management goals that are accepted are outlined here. And again, there is nothing unusual here in this list. We have blood pressure, filling pressures, vasopressors, blood gases, oxygenation, electrolyte, glucose control, and we also manage urine output. And the more of these goals that are achieved, it is recognised that the chance for organ donation is improved, and you can also potentially transplant more organs per donor. So our goal as a managing member of the critical care team is to maintain hemodynamic stability in patients with severe brain injuries. We all know that brain death has many, many sequelae: dysrhythmias, hypotension, hypothermia, acidosis, pulmonary edema, coagulation problems, and diabetes insipidus. And if these are left unaddressed, then you get cardiovascular collapse. Aggressive donor management around the time of brain death can improve organ procurement. Without this, you lose up to 25% of donors secondary to hemodynamic instability and electrolyte imbalance. So this is a very predictable cascade of physiologic events around the time somebody would become brain dead in a critical care unit. Years ago, before people knew better and critical care systems evolved, active therapy may have stopped at the time when it became clear that somebody had a devastating brain injury and were going to progress to brain death. So if active therapy stops here, then there is an impairment to what is the opportunity later on, because with hypotension, diabetes insipidus, electrolyte abnormalities, volume depletion, the serum creatinine goes up, liver function tests deteriorate, and the option for donation is lost around this time. Around the 2009-2010 time, it became quite a frequently described situation in the transplantation literature where if you actually had more goals met compared to not, then the organs transplanted per donor were actually higher when the donor management goals were not met. So there was actually an increased number of organs transplanted per donor. And this is from 2010, but there are many, many presentations where this is emphasized and validated. And again, from somewhere closer to our area, this is a paper which came out of UCI looking at the impact of donor management goals on organ yield. And here they are particularly looking at lung donation, with an increase in donation opportunity from 14 to 36% of donor management goals are met. I think the results speak to themselves. One of the things that I will just highlight that is something more new in this support area is airway pressure release ventilation. And the people from the One Legacy area who actually manage these patients once they are actually brain dead and formally going ahead for organ donation. They embraced airway pressure release ventilation, and in 2012 put up their lung donation by 39%. And in fact, they are the busiest organ procurement organization in the United States at this time, with the most transplants. There are a couple of background animal model literature citations here, which actually give some validation, and I'm interested as an intensivist. Back east, APRV is used very frequently as the ventilator mode for patient management. Here on the west coast, it tends to be used a little later in the cascade of requirements for support if people have lung injury. I'll just go through some of these pictures. This is a pig model where the animals were made septic with peritonitis and had shock and all those sequelae. And there are some pictures here with the more standard low tidal volume ventilation and how different the lungs look for the animals who were supported on APRV mode. And again, this is showing the edema in the lungs with low tidal volume support, and APRV supported lungs had no bronchial or septal edema. These are always good lunchtime pictures. Again, the histology is here. For the APRV lungs here, we see much less alveolar crowding and edema. And here you see the thickening that you would typically see on injured lungs with the more traditional assist control low volume ventilation. Compliance is maintained in the lungs supported on APRV, is distinct from assist control, and this is over a period of 48 hours. Again, oxygenation is better preserved on APRV. Surfactant, again, is better preserved in the animal model with APRV support. And interleukin-6, which is an inflammatory mediator, is hardly there on the animals supported with APRV versus the low tidal volume ventilation. So this actually speaks to the importance of intensivists knowing about these issues, because when somebody is progressing from being critically ill through brain death, there are a lot of metabolic and inflammatory processes in place, and we need to do the best support that we can to maintain pulmonary function. I'll now move to the topic of brain death, and this has been in the news media considerably with the recent pediatric case in California, and you may also be aware of the patient who was supported after brain death in Texas. And even in this day and age, there are many people who do not understand necessarily all the aspects of brain death and how we declare this. So just for completeness, we'll go through the definition of this. It's the total and irreversible cessation of function of the entire brainstem, brain, including the brainstem. And this is the Uniform Determination of Death Act that was initially put forth in 1971. And again, there were some updates in the neurology literature in 2010, and this is the basis of what we are doing clinically these days. For determination of brain death, it is absolutely essential to have a checklist. And importantly, the time of death is when the patient is declared brain dead, not when they are finally taken off support and their heart stops. It is the legal time of death is when brain death is declared. And the diagnosis of brain death before the circulation fails allows organ salvage. And it's really important to know what brain death is and is not. It's a legal definition of death. It is not a decision for families. It is not the same as establishing a poor prognosis, and it was certainly not developed for the purpose of procuring organs. The essential elements are that it is irreversible, it is cessation of function of the entire brain. We need to determine a cause and ensure the absence of confounding conditions. So to establish brain death, we must observe and document coma, absent brainstem reflexes, and apnea. And this is a very interesting paper published in 2008 by Dr. Greer, a neurologist who has an extensive critical care background. And if you look at the compliance with all the aspects of determining brain death, here we are at 100% with coma, 100% get lack of reflexes of the pupils, the cornea reflex 97%, 87% for a gag reflex, and then we get down to the apnea test, and even in 2008 this was 27%. And this year I have already encountered situations where physicians did not realise that an apnea test was a mandatory part of evaluation for brain death. So this is a really important part of somebody's knowledge base. For the brain death, we need a checklist that all the prerequisites are here. And I know we've all struggled with CPOE, but one of the benefits of CPOE is that we have at Hoag, I think, one of the most robust brain death evaluation protocols that's electronic, and you cannot pass to the end and sign unless all these things are taken care of beforehand. And I was very relieved where recently we had a difficult case that actually other lawyers looked at our brain death documentation and it stood the test, so that was good. But many times people do not document no residual neuromuscular blockade. And you have to address acid-base electrolyte abnormalities, make sure that the temperature, blood pressure is adequate, and there are no confounding medication issues. The examination is fairly standard. We just have to go down and ensure that all these vital brain stem reflexes are absent and document them. And then there is the apnea testing, which we have to do, and make sure that at the end of the apnea test, the PaCO2 is at least 60 millimeters of mercury, or in somebody who has chronic hypercarbia, there has been a 20 millimeter rise from the normal baseline value. Ancillary testing does not feature in part of the routine brain death testing. People have thought EEGs and blood flow studies, either by angiography or nuclear medicine, are requirements. In fact, that's not the case. The only time we would do this would be when we are unable to do an apnea test or there is some other reason why another part of the exam cannot be completed. The important thing too is that only one of these tests needs to be performed. And I think the most useful one clinically in our hospital is the nuclear medicine brain blood flow study, although sometimes we do encounter shortages of the tracer. A second brain death exam has been shown to perhaps negatively affect organ donation, and this was a big study from New York area hospitals published in 2011. They were questioning whether or not you actually need 2 brain death exams, and they made the point that none of the patients declared brain dead was found to regain brainstem function upon repeat examinations. So that validates the brain death testing. So their conclusion from the study was that 1 brain death exam should suffice to determine brain death. And I would predicate this to no, it's really important to separate out the adult population and pediatric population, and I'm specifically speaking to the adult population here. So what they found in this study is that the mean interval between exams was nearly 20 hours. It took longer over the weekends, was longer in smaller hospitals, And then, this is understandable, the consent for donation decreased as the exam interval increased. If you've ever experienced any situations in the critical care units, these family members are sitting there tired at this long vigil, waiting and wondering. So this is a natural attrition. And then obviously some patients are very critically ill, and some of these patients actually had a cardiac arrest waiting for the second exam. But however, if you are going to have organ donation, California law requires 2 brain death exams prior to organ donation. So it is our goal in this hospital to have this completed in a timely way, and our goal is for 6 hours between the exams, and this is actually fairly achievable. Gift law is another topic that's central to this process. The Uniform Anatomical Gift Act, or UAGA, is the primary legal authority for organ and tissue donation. And again, it was drafted many years ago, first in 1968, and subsequently passed in every state. The gift law requires 3 elements: intent, transfer, and acceptance. And it is a gift that is legally binding and uncompensated transfer. It is not based on informed consent principles, so this is why the term authorization is preferred in this concept. Informed consent, which we would usually have for hospital procedures as a legal concept, is applying to healthcare decisions where there are risks and benefits to the patient. But here, if somebody wishes to be an organ donor and register as such, this is documentation of their gift, and it is under gift law. So the gift law provides the opportunity to evaluate potential donors at or near brain death, and it is a legally binding authorization to donate. And this grants authorization for organ preservation even if the family objects. And this is a part of the gift law that isn't always well understood in the community. So, to make things simple, if there is donor registration, that becomes the donor's advance directive. The advance directive is the hospital obligation, and that includes all the caregiver teams. Then the donor designation is the hospital obligation. So if somebody becomes brain dead and they are registered as a donor, we have to take this on board and do everything that we can to facilitate the process of organ and tissue donation. The Organ Procurement and Transplantation Network is involved in this. It's called OPTN, and again this was established in the 1980s. And a mix of public and private partnership, and it links all the aspects of donation and the transplantation system. Their primary goals are to increase the effectiveness and efficiency of organ sharing, and importantly, equity in the national system of organ allocation. Nowhere can we turn up with a $100,000 grant and jump up the liver waiting list. Those things just should not happen in this country. And the other thing, the OPTN increases the supply of donated organs available for transplantation. One legacy is our local organ procurement organisation, and again this is another part of the whole process. As I mentioned, they are the largest and most active OPO in the country. They were founded in 1977, are a not-for-profit group. They serve a huge area of 20 million residents, serve 220 hospitals and 11 transplant centres. And we work with them to have shared and standardised practices. We have effective clinical triggers for knowing when to notify them of a potential patient. Timely referral is important. Then they help us with appropriate request, and then working with them, that we are able to maximise eligible death conversion. So in all hospitals, and particularly critical care units in the emergency department, we have these reminders to notify One Legacy if somebody is going to have withdrawal from life support or if somebody is comatose. And importantly, every death is notified within 60 minutes, and this is for both brain death and cardiac death. This is actually also a CMS requirement, and in the Organ and Tissue Donation Council we are working very hard to maintain compliance here. For eligible donors, it's important to know that the criteria for donation are constantly changing, like many of the things in medicine and surgery. And patients with HIV, malignancy, and at the extremes of age should still be referred to maintain the opportunity for organ and tissue donation. Eligible deaths in our area, I thought it was interesting to show you a few slides from the One Legacy database. And really there hasn't been all that much difference between 2009 and 2013. This is where they looked at the data for the first quarter of each year. Timely referral is really important, and we can see here from some national data there is a difference between 59 and 71% of conversion rate, and this is in the person who would not be a registered donor. This is the family giving consent. So you can see how important it is to have timely referral to improve this number. The effective request process needs to be understood by all in any hospital system. A family needs to be given an opportunity to make a decision about donation if the patient is suitable as determined by One Legacy. But really important, it is imperative that only somebody from One Legacy approaches the family of a potential donor. And donation is not part of the end-of-life conversation until One Legacy has been involved. If a family member brings up the topic of organ and tissue donation prior to brain death, it is our responsibility as caregivers to have a scripted response to the effect that we are part of the caregiving team, but we will put you in communication with experts who can help you with these questions, and then you exit the stage. Family support around this time is really important. There needs to be really good communication with information that is understandable. Caregivers need to be giving one consistent message: what happened, why, what happens next, what can we expect, are very frequently asked questions of the caregivers. Families need hope, respect, leadership and guidance, reassurance and support throughout this time. And there are many people that we can bring in to help with this, particularly social workers, the CARES team and clergy members. For the effective request process, the family needs to be well informed. There is usually a pre-approach huddle so that the family's culture, language and religious beliefs are understood. And then the appropriate request is made in the appropriate setting. Effective request data, again from national numbers, shows that there is an increased conversion rate with family consent from 47% to 76% if there is effective request, again attesting to this being important. This shows, again, some One Legacy data. These are the total authorisation rates, and this is actually the amount of non-registry patients who became donors. And this is fairly constant across the years. Interesting to look at what happens in our local community too. The Hispanic, white population, African American and Asian people. These are figures for the first quarters for the last few years, and again there is an increased donation in the African American and Asian population. When we get to donor management, it's a very complicated team with the organ donor here You've got the bedside critical care team, there is the OR team, scheduling and transplant surgeon, the family is supported by all the members of the hospital services, and then there's the one legacy component to this. What do transplant surgeons want? They want young organs, organs without chronic disease, immediate organ function, and great long-term survival. Life isn't always that easy. And there are, because of the pressure on the waiting list, increasing use of what we call extended criteria donors who may be older or have some organ dysfunction. And it may be interesting for you to know that if you have a young patient, say after trauma, who is on dialysis acutely for acute kidney injury, these people can actually donate kidneys because they will be transplanted into a patient with chronic kidney disease on dialysis, and then there will be usually good renal function recovery in 4 to 6 weeks. So there are many things out there that we need to know about. Donation after cardiac death is also another area. It's also referred to as donation after circulatory determination of death, DCDD. And interestingly, this is about 50% of the patients who are organ donors at Hoag. It provides another option for patients' families to consider following the decision to withdraw life-sustaining support. And we are, as a hospital, actually required by the Joint Commission to have this program available at Hoag. The family would make a decision to withdraw life support, independent of and prior to any discussion regarding organ donation. Suitable patients for this process are expected to expire within 1 hour after withdrawal of life-sustaining treatment. Consent for the process is obtained by one legacy, but importantly, different from organ donation, this patient is not brain dead and continues to be a patient at Hoag Hospital managed by our hospital medical staff. What happens is that the patient is taken to the operating room, life-sustaining treatment is discontinued at that time, the patient is extubated, procedures are discontinued. The family is usually present in the operating room at this time. Death is pronounced in the operating room, and then organ procurement commences 5 minutes after determination of circulatory death. It's said that 1 in 3 patients may not expire within the required 60 minutes, and that requirement is because this is warm ischemia time, so there is a potential for organ damage over this time. However, we've only had 2 people return from the operating room to the units over 5 years at Hoag, so we have actually had a very successful program. It is really important for the patient to return to the ICU from the operating room if they do not donate, because of the whole group of people there. You've got the family, the nurses, the physician, and the patient, and there is a sense of disappointment, so we need to help people through at this time. And if you look at this is the percent of donors recovered through DCD. This is national data through June 2013, and it's gone from 2 to about 13.5%. So this is an important part of donation. And DCD donors, just locally, up to 2012, One Legacy had a rate of approximately 10%, and that's going up. Tissue donation is very important. In fact, one of the things that sparked my interest in this whole topic was learning that Hoag has the highest rate of tissue donation in the Orange County area. So I think we can all be really impressed and proud of that. And then again, this is just the numbers of registered donors who gave tissue and who were non-registered, and this is 2009 through 13 from One Legacy. Organs are also taken for research to help with the program, so not all is lost. It's important to know that 19 people die every day in the United States waiting for a needed organ. 3 people die every day in California waiting for a needed organ. And then there are those people who are removed from the waiting list because they're too sick for transplantation. And again, I just get back to how much the LA area features on the California area wait list, and then the preponderance of the California wait list to the national wait list. 49% of the US population, 18 and over, is a registered donor. However, I don't understand why only 30% of the eligible population in California is registered. We have 18% of the waiting list and 38% of the LA area waiting list. So it's really important to take this on board and do all that we can. So what do we need to do? We've got more people on the waiting list, and the number of organ donors is relatively static. So we need to recover more organs for transplantation. So the number of organs transplanted per donor is slowly going up. This data isn't entirely clean because with donation after declaration of circulatory death, we cannot get up to 8 organs because of warm ischemia, and unfortunately the national and local data combines these two. So there are many patients who may give 5 organs, but it's not easily reflected in this data. So this gets back to what we need to do in the hospital is have impeccable donor management goals. We need to have an effective request process. I'd just like to share with you some of the new things out there. There is something called ex vivo organ support, and this is actually working in the area. It's called Heart in a Box, and what somebody will have is a heart taken out by a surgeon, and then this is maintained in a circulation system, and the heart is actually beating at normal temperature, and then there are all sorts of physiologic values that are here. One of the advantages too is that you have criteria for transplantation, and I have heard a transplant surgeon say that over a few years there were actually 4 hearts that would have failed should they have been transplanted that were picked up actually with support in the system. The other advantage of this is that there isn't quite the rush to get from the procurement hospital to the transplant hospital, because there are limits on how far organs can be supported between procurement and transplantation. And Dr. Selecki, you'll be interested to know with your pulmonary background, this is lung in a box. So here you actually have lungs being ventilated and circulated, and then if pulmonary physicians need to actually do a bronchoscopy, there's a little port that can go in here with a bronchoscope. And last but not least, we have liver in a box, and this process was recently started in London at a university hospital, and the liver's actually in this box here. So again, livers don't last too long with warm ischemia. So you pack them up and perfuse them, put them on wheels and in trucks and aircraft, and there's your liver. So getting back to what we all hear about, this is very much a human issue with human impact, and I think it is important for us as individuals to think about. We need to think about this in the hospital and also the community and society. So what can we do? We need to become a supporter. We need to become educated. We can educate. We can be a hospital champion, a community champion, and most of all, we need to register as a donor. It's important to say thank you to the people who allowed this process to happen, and this is a picture of our Tree of Life and the artist who donated the design, and this is our Book of Life with both tissue and organ donors that's outside the chapel. And the donors, with permission from the families, have their names on the leaves here. So my goals for this presentation were to discuss aspects of donor management, best practice, and at medical grand rounds to obviously identify what the physician's role is, and then to discuss donor hospital best practices. So I'd like you to take this on board and ask yourself, how can I use this information to improve donation practice at my hospital? Thank you.